Okay, everybody, welcome back to the Summer of Protocols guest talk series. This series is part of an 18-week program where a cohort of 34 researchers are exploring the various aspects of protocols. You can find out more at summerofprotocols.com. Today, we're talking with J.D. Nolen about healthcare protocols. Our next session will be on Friday with Sarah Perry. The pre-meeting reading material is linked there in the program calendar at summerofprotocols.com. And with that, I will hand it off to Venkat to go ahead and introduce our speaker today. You're muted,
All right.
Venkat.
So today's session is a topic I'm glad we were able to include. So one of the challenges in composing this program was we were trying to have a bunch of topics that connected well to each other, which meant that sometimes important topics with a lot of relevance to protocols, it was hard to incorporate, but healthcare is one of them. There's so much protocol technology in healthcare at all levels, from the informatics stuff that JD's going to talk about today, to how doctors and nurses interact with patients, to, I don't know, I guess scientific ideas about how a particular disease is treated. So it's like protocols from top to bottom all the way down. So it would actually be nice to do summer protocols type programs entirely about healthcare protocols. I think you could fill it up in a minute. But yeah, let's see how far we can get in increasing our literacy in an hour. So over to you, JD.
All right. Thanks for the time, guys. Let me share my screen real quick. And make sure it's coming through. There it is. All righty, folks. Yeah, so we're going to chat about protocols under the guise of healthcare. And I titled this as the structural change that healthcare needs, but probably won't ask for because it's too busy doing usual healthcare stuff. So, quick little bit about me. So I describe myself as the engineer who went to med school. I'm steeped in building things since being a kiddo. So I'm an engineer by training, but yeah, I am a doctor. I've been working in the healthcare informatics space, both the commercial side and the academic side, for years. So I eat, sleep, and breathe this stuff every day. Currently, I'm the chair of the Department of Pathology and Lab Medicine at Children's Mercy Hospital here in Kansas City, Missouri. And I'm also, and this will come up later in the talk, I'm the co-chair of the Orders and Observations Working Group at HL7. And that'll make a lot of sense as we get towards the end of the talk in terms of where we can go and what we can do. So first off, I want to do a big thanks. So first, big thanks for the summer protocol organizers giving me a chance to talk for this. This is great. I love the ability to share just some ideas and concepts and places where I truly think the protocol mindset can really make a change. Next up, I want to thank Kevin Iwaki and the folks at the Green Pill podcast, because I learned about all of this because I was listening to this podcast episode while driving on spring break, which had Venkat on there. And so without that, I wouldn't be chatting with you guys. And then, of course, I want to thank the audience for just being curious and coming and taking a listen. So as Venkat mentioned, healthcare is big, gnarly, complex and stuff, but let's start really basic and simple. You might have seen this old Norman Rockwell painting where you've got the country doc physician who is doing a physical exam on a child's doll. She's probably there for a shot behind the scenes, but at least this captures the nice moment before, though. And we're going to come back to this picture a couple of times in the talk, because this type of interaction is really at the core of everything for healthcare informatics in terms of the protocols we're going to chat about. So, present state of healthcare. Well, you can think about it as this complex set of interactions and workflows all layered around one thing. Do the right thing at the right time with the right patient, period, hard stop. All that we do, no matter what part of healthcare you're working, is for this. Only that is truly at the core. So to help conceptualize that, let's use a very simple use case. We're going to have a clinic visit. You can translate this into something more complicated if you'd like in your mind, like someone's having surgery or someone's getting a medication. But I figured let's just start with a basic clinic visit and go through that workflow to set the stage for using protocols. So let's say a patient needs a physical exam. What are the steps involved in doing that? First off, the patient has to go find a provider. They have to find someone that can actually do that type of work for them. In the medical landscape, things tend to be specialized. And so one entity may not be able to do it while another entity might be able to do it. So you have to go find that person to do it. They're usually not reaching out to you per se. Maybe you get a nudge from your healthcare plan that you need a physical, but by and large, you've got to go find that. Next, you have to make an appointment. Is that person that said, hey, I can do that, are they available to do the work? So you make the old appointment. Then you show up at the clinic and you sign in. Now, this is the fun part of the process, to where you physically go there, but then you're also confronted with a layer of steps that I've buried behind the phrasing signs in, to where you do things in terms of who you are, what you want, what do you agree to, etc. Then after that, you step into the exam room where the work is going to take place. The provider enters the room and identifies both themselves, I'm Dr. So-and-so, and then they look at the patient and go, oh, you're Mr. Smith. And then, so we've got a little bit of authentication, identification going on. And then the provider performs the work, whatever. In this case, it's a physical, but it could easily be surgery or a pharmacist filling the medication. No different. Work being done. Then, of course, you document what you did and you communicate what you did, what you found to the patient. In this case, it's a physical. So typically, let's pretend in this case, the patient is someone doing a high school physical exam so they can go play sports. Okay, kid, you're great. Your heart sounds fine. Your lung sounds fine. No limitations, range of motion. You're good to go to play football. Lastly, after documenting it, that provider EHR stands for electronic healthcare record. You also might have heard the term EMR, electronic medical record, essentially the same with some tweaks. Sends that finalized report to the patient's personal health record. So this may be a portal the patient can log into and look and see, okay, here's my healthy physical. Maybe they have to show that to whatever sports agency so they can go play. And then potentially nowadays, a lot of these records get moved into a common healthcare exchange so other entities can look and see that record to help break out of some silos. Now, you can style all that out into a workflow. And for just our basic, simple example, this is the kind of workflow you start to quickly find yourself in. Lots of yes, no's, lots of is this present, not, various steps of getting things approved, moving the patient around, getting ready for the work being done, once the work is done, documenting it, etc. So it is a very complex multi-step process, even for just the simple example we talked about, getting a high school physical. And if you zoom out a little bit, this is what the current landscape looks like. I mean, and this is even a simple slice of everything. In this case, this diagram was built with the health record in the center. Here's the patient at the top. And around this record, so if you go with the logic of, okay, the record being the single source of truth, aside from the patient being their own historian, if you will, all these entities both generate data, put data in, and they've got a workflow. So they're living on top of this infrastructure down here. And it comes in a variety of shapes and sizes. That EMR, EHR I talked about, that's there. You've got lab systems, radiology systems, pharmacy systems, billing systems, coding systems, image systems. Everything in the world with a system attached to it supports this workflow. And the data has to move back and forth. And then on top of that, you have to go through various steps of who can do what, when, and where for this patient. Because we get back to that core principle, you're trying to do the right thing at the right time for the right person in a way that works and flows. And so you can see how complicated this mixture is, and it only gets more complicated literally almost every day as we add in either a new thing, a new workflow, a new protocol, not our kind of protocols, but workflow kind of protocols, to get things done in terms of being able to take that patient from wherever they are with their current state of health to a better state of health. So of course, as everybody knows, the system is not working well. I would pretty much say, regardless of where you are on this planet right now, the healthcare that you're getting use a little bit of a tune-up. And so the reasons why, as Venkat said, we could spend weeks talking about the reasons why. Yes, there are inefficiencies in the system. Healthcare is a beautiful thing, but it moves so fast, sometimes we don't even have a chance to pause, breathe, and look and go, is this really the best way to do stuff? So we have lots of inefficiencies. Case in point, go visit your local hospital that's growing. You will find a variety of buildings that all look different because they're all built in different years. And you'll start out on floor 2 and end up on floor 3 in the hospital and come back to floor 1 without even actually going upstairs, downstairs, or using an escalator. The system is inefficient. There are gaps in care. Who has run into the scenario where your record couldn't make it from A to B, and maybe you had to bring your record from A to B back and forth? There are gaps. There are places where some care just stops, and you've got to figure out how to get it as a patient to the other side, which of course that's not efficient either. But there are gaps and shortcomings where things just don't seem to happen the way they should. Misaligned priorities. This is a larger topic. We're not going to get into the payment side of healthcare with this, but you can clearly see how, based upon incentives and behaviors, priorities can become misaligned, behaviors become misaligned, and the overall output of the healthcare entity can become misaligned. So again, that's a topic in and of itself. Wrong tool, wrong job. Healthcare is great for doing these, what I would call a skeuomorphic failures, where you'll take something that looked great over there and you'll make something that looks just like it and use it over here, but it's the wrong job. It's the wrong tool. And you don't think, what's the better way to either model this information, model this data, or model this workflow and build the right tool for it, as opposed to just repurposing something from the past without even thinking about it. So, given all that, we have gone through multiple changes in healthcare trying to make the situation better. And this is happening across the globe in various ways at various stages. And for this, I'm going to focus down on just the information side of what's going on. So the first big wave of change in healthcare, as it started to grow out of the country doctor in the picture we started with, is can we get the data to move a little bit from two healthcare entities, say the doctor's office into the hospital health record? So people came up with, all right, can we use some type of data standard? At that point, we were starting to get some very, very bare bones information records. Some were in the lab, some were at the bedside. But could we make it to where the standard data would move back and forth? And so healthcare informatics, which is this crazy intersection of healthcare, computer science, and data modeling all together, that's the place that I live and breathe every day. We've been using standards for decades now, and it's really become almost a standards first type approach in healthcare, which is better than where we were. So there are core information standards that we borrow all the time that we use, things you've seen these already. Web standards, XML, JSON, out. I mean, the list goes on and on and on. Stuff that's already literally off the shelf in use in some other industry. We'll obviously take that, grab that, and reuse that for our purposes. But when you start to chat about healthcare, then you got to think about two big core concepts. One, how do I represent a healthcare record? So I trained in med school back when it was a split world between an electronic world and the paper chart. And you had the paper chart for documentation, and some things were in the healthcare record. How do you represent a patient's healthcare experience electronically now? Because the paper charts were great from a UI perspective. Nothing was easier than using your pen and a piece of paper, but you can imagine all the problems with that kind of record. You lose it, it's gone. You can't read my handwriting, so it's illegible, you can't transmit it, and on and on and on. But how can we represent all the data that a patient interacts with in the healthcare system? Flashback to that diagram I just showed you with all the various entities that are around the person in healthcare. How do you capture all that into a record? And then how do you transmit it? How do you move it? It's one thing to capture it at hospital A. How do you move that to hospital B, C, and Y, or a doctor's office, or the sports organization that need that kid's physical so they can play sports? How do you move that around? So we built standards for that. So this is where you start to get into some of the alphabet soup of healthcare IT. HL7 V2, HL7 Fire. We'll do Fire in a second, but V2 was the first pipe, if you will, to move the data back and forth between various entities in healthcare. CDA, that's the way we can structure our documents. DICOM comes up when you chat about images like radiology and stuff. And so this alphabet soup was built, and it's still growing, to be able to land on a common language, a common framework, a common standard, so you can actually move this data around and represent it in a way that was consumable both by a person and potentially by a machine. Then on top of that, being able to make healthcare data computable, that was the next sort of phase of standards, to say, okay, can I put a code on this? Can I represent this knowledge as a computable code? That way it's easier to interpret, transmit, and potentially do work on top of, because I don't have to parse all this text. I can just say, oh, that code means that patient had high blood pressure. So we use things like SNOMED and LOIC and ICD-10 and UMLS and on and on and on and on. There are all these various code sets that we use to help represent the data to make it truly portable. Then lastly, we do profiles. And so profiles are the way that we would orchestrate all these various interfaces and things together. And IHE is one of the big drivers for that, to where we build out the actual workflow. We say, okay, this is what the standard workflow would look like to move a tube of blood through a clinical care lab, like the one in my hospital that's across the hallway from me right now. How do we stitch all that together to make it to where, okay, this is a standard workflow. So if you follow this workflow and you use the data sets we've talked about and you use the messaging frameworks we've talked about, you can easily move the data between, say, the instrument and the lab system, and then the lab system can go to the EHR and then hopefully get to the patient and the provider. So a quick peek at what current state looks like. This is a V2 message. And right now, this is still powering the lion's share of healthcare on this planet. This is how data gets pushed around between various stacks in healthcare. It is a pipe delimited set of messages inside of a big string. This is a conventional order set looking for, you may see the word hemoglobin and things like low and comments. This is what that looks like when your provider is ordering, say, a complete blood count. They want to know, how many red cells do you have? This type of message gets generated from where they are electronically and sent over to the lab to go do the work. And this has served us really well, but it doesn't scale that well, and it's a little too customizable. The other thing that I mentioned in terms of transmitting, we also have documents representation. And coming out of V2/V3, we built this thing called the CDA, and this is clinical document architecture. So this, you might recognize this, it looks like XML because it is, but it's a standard way you can wrap a healthcare document to make it truly portable. VS move some vision around, and then we've got CDA as a box, and we also have document as a box to put information into and start to ship it. So we get back to this whole world right like this, and when you look at it from an interface perspective, it starts to look like this. And so you have these things that will pop up like interface engines, and here's our old hospital system. So this is where the EMR is living, the LIS is living. And you've got all these messages that are now zipping back and forth, moving data back and forth. It truly looks like point to point, or the old for the airlines that they use. You know, I'm from South, South Delta, you always go through Atlanta. That's the hub and spoke. Same kind of concept. It works now, it's serving it, and it's connected. However, everything is still separate. And there's a lot of these modules, there's a lot of redundant functions. You've got, yep, I'm back. Hello. Can you hear me? Hello? Hello?
Yeah, I think we got you now. Maybe not, though.
Venka, can you hear us?
I can hear everybody, but not JD. I think JD dropped
there.
out. Oh,
Yep.
There he is.
Hey, I'm back. Sorry about that. So, and here's the map. And so you can see everything's connected. It's all point to point, but there's lots of redundancy in the map. Lots of authentication that everybody seems to be doing, lots of authorization. None of it is really shared. It's still lots of silos, lots of messages back and forth. So because of that, you've got lots of these brittle connections. When you talk to people who live in the space, like I do, and people talk about, oh, let's do a code upgrade, people get nervous because you're wondering, okay, which one of these things are going to break when I upgrade one of these things? Very, very brittle. So what happened in HL7, and this is the group that I work with since 2010, to where we build these healthcare standards, was we started to see back in around 2013, 2012, 2013, 2014, that all these new interfaces, these web services were becoming more the norm. And HL7 v2 was looking a little dated. And we thought, could we do this for healthcare IT? So some very smart folks like Graham Grieve and others came up with the idea of making a web service-based appliance for healthcare IT. So they came up with FHIR. FHIR stands for Fast Healthcare Interoperability Resource. And it allows you to build a RESTful type API on top of your healthcare stack. So anybody on this phone call who's ever built an API for anything or interacted with one to move data around, if you've done that, you can easily do FHIR because it will look very familiar to you. It's a RESTful type architecture, and it uses current web standards to get the work to happen. And so we've been building this for the past almost a decade now alongside our current V2 appliance to help open the door for something that potentially could come next on top of that, a slicker type interface that supports more of a conversation, if you will, versus the old order and result back and forth. And it's really easy to read the spec. And of course, there's ontology. There's always ontology what we do, though. That way we can map these codes to meanings, etc. So with all of that, you might say, hey, this is starting to look like a platform. This is starting to look like something where you can do plug and play work. And yeah, you're kind of getting there. So since FHIR started, people said, hey, wait a minute, because all these EHRs have a really basic web browser inside. So when I say EHR, I'm talking about something from, say, Epic or Cerner or Meditech, et cetera. People started to build these little JavaScript web pages that could run inside an EHR that could leverage these FHIR resources to say, oh, okay, I can make the data, move the data around, and do kind of the old write once, run anywhere kind of thing. And so now you've got a platform. So you're starting to help the data move a little better. You're cutting away a little bit at some of that point-to-point work, and you're making things move in a different way that's a lot more open. And so hats off to Simone for his talk, I think it was about a week ago, about platforms, protocols, architecture, infrastructure. The world of healthcare IT looks a lot like this diagram right now, to where we do have infrastructures. Your mainline EHRs, like I have here at the hospital, we run Cerner, other places run Cerner, Epic, et cetera. And then you're starting to get, thanks to this FHIR layer, a place where you can aggregate data, you can build stuff on top for developers to where someone who is not a member of a company that built your HR can build an app per se, and it plugs in and runs, and it can provide an advanced workflow for that. And there's a little hint of a potential marketplace for that. So you can see this landscape to where it's kind of getting there. It's a little lumpy bumpy, but we're getting to the world of where we've got an API that lives on top of most of our EHRs right now. And you can go out and you can go get an app per se that runs on top of it. At my hospital, we have one that's running now that allows a provider to look and pull it based on the data of the patient that's in front of them, pediatric patient, can align the right type of resources in the community to help take care of that patient. But how's that happening? Well, you've got that same architecture we just talked about with APIs to let the data start to move. You can kind of say, I can see some protocols in here, but they're not at top level. Just keep that thought in mind. But you've got that app layer, foundational layer, it looks like a platform, gets us a little better, and hopefully chips away at some of the noise. So now, where exactly are we now with that landscape? With that, so what's going on? Well, sadly, the dance is still about the same in terms of how we evolve and get better in healthcare. And the following slides I'm going to show you came from a deck that I gave in 2014 with Sandy Arison and others around the Digitize project, where it was part of Institutes of Medicine project to help make genomic data more liquid so it can move around. So the typical process of change in healthcare data starts with this. You'll have someone, either a provider, maybe a lab, maybe somebody else say, hey, I've got some new data. Either I'm making the data or I'm a provider. Hey, I want to see this data. How do you do that? Well, the next step is you end up looking at, okay, what infrastructure am I currently running? And how well does that play with the data that I want? Who's got the data? Where is it? Then next, you look at, okay, how do these things cooperate? Okay, data's over here. Can I get it over here? I don't know. Is there an interface? Do you need to build an interface? Then next up, okay,
I think we lost you.
Hey there. Hello, can you hear me now?
Yeah, we can hear you.
Okay, good. So then you end up saying, okay, can we standardize that interface? And then the magic question, hey, how do we get this built? How do we pay for this? How does it run? And then the government, of course, is in there saying, okay, what you can do, what you can't do. So this dance is still going on today. It hasn't changed that much. And of course, the thing that we didn't have in the diagram to begin with is the patient. So we've still got this well-orchestrated dance of how do we improve healthcare? How do we work through all this kind of stuff around the patient? And I think we can do better now. So let's go back to this provider-patient interaction. So what's going on here? Well, first off, for that doctor to put the stethoscope on this toy doll, obviously the girl had to give permission. Yes, you may examine my doll. Then authentication. Okay, I'm going to sign something, say, okay, I agree to this. Competency. If you see in the back, that's a medical diploma right there. It says, oh, you're a doctor. Okay, you've got a diploma. Or maybe you did your continuing ed credit, or you did some sort of exam or something to certify the fact that, yes, I am competent to do the work you're asking me to do. Then you perform the work, examines the child, examines the doll, document what you did, and then you exchange the data back and say, okay, here you go. Either I tell you, or I go back to you in a report, etc. So now if you look at that from the lens of protocols, you've got availability. Who can do the work? That could be a protocol. Can you find the person to do the work? Authentication. Who are you? You've asked to do the work, or you're asking for it to be done, but exactly who are you as a person? Permission. Are you allowed to do that work? Am I letting you, yes, please give me a shot, or yes, please amputate my leg? Does the patient give permission? Competency. Can you do the work? That's a fun one in medicine, and we assay competency all the time through various performance exams, continuing ed credit, documentation of work, quality surveys, etc. Can you do the work? Performance. Did you do it? If you didn't document it, it didn't happen. How'd you do the work? Did you record it? Did you tell anybody about it? In exchange, can you or did you share the work? Can you get it to go from your chart to the patient's chart, back and forth? So using all these protocol concepts, then we go back to our own physical exam example. The patient finds a provider. That's search. That's availability. The patient makes an appointment, a request for work. The patient appears at the clinic and signs in, authentication and permission. The patient gets escorted to the room center. That's transport. You're moving something from A to B. That's another protocol. The provider enters the room, identifies themselves and the patient. Authentication. Who am I? The provider performs the exam. Performance. The provider documents the physical exam and communicates findings to the patient. Again, documentation, exchange of results. And then after documentation, the provider's EHR sends the record to the patient's personal health record and or the regional health exchange. And that's now I'm exchanging data. So it looks like protocols. It seems to act like protocols. The question, where are these protocols right now? Well, they're here, but they're all trapped. Every one of these things in here that's interacting with the record and with the patient has protocols. Most of them are native, built into the stack, or they're not overtly captured as a protocol, but it's all here. It's just not formalized as this is a protocol. And this is one of our true problems in all this, because there's a lot of redundancy that lives alongside all the brittleness of this architecture. Because despite the fact that we are all connected and data is flowing, it is still a very fragile setup, a fragile system. So I have true protocol envy when I look from my spot in the healthcare landscape to what happens over, say, on the DeFi landscape. And I see all these things that have appeared. Ethereum started, 2013, 2014. And that slide deck I just showed you with all how the change process typically happens in healthcare was about the same time. And we're still running at about the same pace with that exchange diagram. And all this has happened over in the DeFi landscape, handling lots of services that were originally only available through traditional finance means. All of this grew out of an ecosystem. So my question is, looking at the healthcare landscape and saying, well, we have things that look like protocols, almost act like protocols. Is it possible for us to activate a true layer 2 in healthcare? Can we do that? Can we find a spot? Because if you look at our landscape right now, you've got lots of, I would call, legacy institutions, legacy infrastructure. And they're there with well-intentions, well-meaning, but because of the way things are constructed, change is hard. Now, can we find a place in healthcare where the following are present? Where the tech landscape for that little area is still mostly a flat green field? Can we find a spot like that to where there's not a lot of incumbent tech that's there? Okay, that's one. Number two, the need for work and exchange are really clear. So can we find a place to where there's a definite need to get work done, moving data around, analyzing data, et cetera, doing this protocol type work, and the exchange needs are really clear. So you can truly see who's making the data, who's consuming the data, and it needs to be moved around. Is there a place where that is really clear, where the actors, the use cases are easily seen? Number three, this little spot needs to have what we would call a homebrew mindset. Places where you've already got people that are doing some initial work, and most of it is homebrew. There's lots of DIY going on to try to make a good faith attempt at making it better and making it look like a layer two. And that this little space, it really calls out for a distributed architecture to where it's not just asking for another big silo. It knows that it needs something that's distributed, something that is global, something that's connected across institutions, and that is truly the happy path for this. And I found there's one spot I believe that we can do this, and that's in the world of genomics. So, genomics, precision medicine, in a quick nutshell for those of you not well versed in this. Think genomics, think analyzing a person's DNA. You are doing it either just to see what do you have, what risk factors you have, maybe you have a disease, maybe you have a tumor, et cetera. You're taking a look at a patient's DNA. And off of that large data set, you're finding out meanings, you're identifying findings, and you're using that to decide about how to treat you as a person, how to find more patients like you to maybe guide a research project, clinical trials, taking this data and weaving it into a workflow to where you can say, okay, because you have this genetic variant, I know I need to not give you this drug because it carries a bad outcome for you. That variant's not a disease, but it's a condition, and I want to steer away from that and give you a different drug. How do I help you become a healthier patient? Well, I know that you're at risk for this disease, so let's do this lifestyle modification. All these things are coming out of genomics and other things that have the word omics at the end, but it's big, bulky, complex data that doesn't conveniently live inside a lab system or an EHR. And the industry, healthcare IT industry, and the healthcare industry are crying out for it. We need this data, we want it to work, but the weight of all this data, all its complexity, is not setting well in the current architectures. It's really stressing it out. It's making it break. It just doesn't fit. And we've got business models that aren't really fully baked about how to do this kind of stuff. And so this feels like a good landscape because it's kind of flat. You've got some early adopters in this space, but it's not ubiquitous. And you've got a lot of people that work in the space, and it's mostly a lot of homebrew technology. A lot of people, the early adopters, they built their own systems for it. I work at an institution that has a lot of homebrew in it that does this type of work. But there's this clear goal of, can we make this standardizable? Can we make this portable? Can we make this connected? Because ultimately, flashback to that patient in the center of it. Can we get it back to where it's the patient in the center so the data can move? So, out of HL7 and other groups, we've got an accelerator called GenomeX. And so this accelerator, GenomeX, has a big goal. It wants to make an open, scalable genomic appliance that can act as a permissioned repository for genomic data and use healthcare standards like the FHIR specifications I just chatted about with HL7 to move the data around from the various players. You can see the data flowing in down here where you've got a laboratory that's doing some genetic work. It goes back to a healthcare entity. It might flow into the HR, or it goes into this repository. There's a back and forth interplay of the data there. It can also go into a registry, and a registry is a place where people with a certain disease set may be listed, privacy friendly, of course, to help guide clinical trials, research studies, et cetera. On top of that, you can imagine pharma and payers, government organizations getting again, privacy friendly look at it to help guide what they do. But the core thing in the middle is this genomic infrastructure, which exists in various portions across the healthcare landscape, but it's not unified and it's not synergistic with itself. So this is the big idea that GenomeX has, that we at HL7 are working with GenomeX to help pull this off. Now, why to do this? We talked about it. It's the big bulky data that's got to move around, and we want to be able to standardize this operation of the data moving around. And when you see this, you think, this looks like a protocol. Are you authorized to put data in the repository? Who are you? Where'd this come from? Oh, you want to share it? Okay, did you share it? How did you share it? All those questions we came up with protocols when we were going through that simple clinical workflow, either out of the Norman Rockwell painting or with the person going to get a physical exam. It's no different. All these protocols are living right in here, so keep that in mind. So some of the proposed modeling that we're doing in HL7, we're building out these workflows, and yes, they start to look a lot like protocols in terms of getting the data set, getting the data modeled the right way, getting it captured, and getting it to move around the system in a way that looks like a protocol. So our current approach that we're going to do for this is we're in the process of styling out what this architecture would look like, how to get it funded, and this is a very what I would call a very traditional approach, where we've got some grants out there we want to get after. We want to build this type of infrastructure, get a pilot, get it deployed, off we go, and at some point transition this maybe to and managed by NIH or others. That's the conventional way. So, but I've got another thought that I brought up to the group. When you look at what's in here, you start to say, okay, it's got a kind of you've got some kind of UI thing, you've got some API thing, and you've got a repository thing. And you start to look at, this is all like a protocol, that kind of thing. Could we, on another path, go back to that page I had where I had complete envy of all the stuff that happened in the DeFi world? Could we take some of those building blocks, leverage some of that stuff, and end up making a distributed architecture out of this that had that true open public resource? And it was powered by protocols at the top layer. And it would give you this privacy first, permission powered environment to where you could truly interact with this genomic data. And we could build this alongside our current plan for architecture like this. And these would essentially end up being one and the same. We would still, it would look like this, but it may behave like this on the side as we start to use some of these other Web 2, Web 3 building blocks to make it to where we could say, okay, yeah, here's your EHR, here's your Fire API that we talked about, but instead of following a traditional Web 2.0 type interaction, we're going to put a protocol layer in between, and we're going to be able to orchestrate that workflow and use those core protocols we've already talked about to be able to give you that layer where you can have a composable workflow. You can bring in governance, regulation, et cetera, and then really styling it out in a way that lives truly above the layer, and it brings protocols into healthcare IT in a way that's not highly disruptive, but very synergistic and lets us grow, because this place in healthcare IT needs significant horsepower, if you will, to go in and do, and we are really on the edge, I think, of a better business model on how to get this work done. And I truly believe building it with a protocol first mindset is really going to help us get there. So I know that was a lot in a little, and apologies for the audio glitch in the middle of it, but I'll stop here so I have some time left over for questions.
Awesome. Thank you so much, JD, for that insightful discussion. And looks like we have some questions coming in. But yes, if you have a question, go ahead and raise your hand in the Zoom chat here. So Dorian?
I know I'm quick draw McGraw on the question thing. I'm not getting like a reputation for it. So one thing I am very interested in vis-a-vis electronic health records is information security, and I have absolutely no understanding whatsoever of like to what extent are health records walled off from others, like when and where does one's personal data slosh around with other data? Just another sort of related question is, is part of the reason why healthcare informatics protocols are pent up, because of the privacy, liability, centralized funding, et cetera.
Yes. Okay. So working backwards, everything that you said at the end is most of the reasons why. So things that go in place right now to make sure your record's not zipping around. So take a conventional healthcare record that's installed at a hospital. To interact with that record, you go through a various login system that's saying, okay, who are you? What are you geared for? What's your role? That kind of stuff. All the interfaces that potentially move your data around, be it to another lab, another EHR record, those are, one, they're encrypted, but two, those are permissioned exchanges that only happen when a patient gives the thumbs up for the record to go based on certain privileges and stuff that have been expressed by the patient. So all that is tightly regulated. And you can see, one, everybody in healthcare lives in fear of the breach of the data that gets let loose in the wild, that kind of thing. And so, which is a thing that you obviously don't want to have happen. But the flip side of that is it constrains the data so much to where either you've got the data encrypted behind a wall vault, or it's encrypted, moving back and forth, to where trying to add on the next level of thing becomes a little more hard because you've got these built-in silos. So I think the challenge we would have as a group is to say, okay, how can we truly get the data up in a way that is privacy friendly, but it is still distributed to control access? You can imagine if you took your healthcare record and you laid it out and said, okay, what things do I never want to share? You put those over here. And then what things, I'm okay sharing that, you put that over there. Or what things can you share, but as long as you window out who you are, obviously your name, your address, et cetera, I believe there's a happy path for us to be able to do all those things in a distributed layer that is still privacy friendly, patient first, organized. But it's that legacy architecture that truly holds us back for some of these discussions.
How big does one of these things get? Like over the course, I'm assuming it starts off small and it gets bigger, but I don't know if you're going to measure that in say RDF statements or something like that. Like how many, because bytes is probably a meaningless, unless
it is. Yeah. God, okay. This is data information, but 2014, if you had a fully instrumented client that had all their interfaces up, everything about the patient captured, bed, temperature, movement, everything like that, it was cranking out more data than Twitter was in 2014. And that was for one patient kind of thing. And so that data set's exploded. But when you tease that data set down, a lot of the data is operational. Who did what, when, and where. And that's not your healthcare record. It's adjacent to. So this is why I think if you come in with both the lids and the knife of protocols, you can really clean that stuff up if you're able to get the authentication authorization layer standardized to where it's one thing, it's distributed, so you don't have a single point of failure, but it's not this redundant at every single silo trying to make sure, okay, this is good, this is good, this is good. No, it's good. I trust it once. Does that make sense?
Yeah, it seems almost as if healthcare data is a narrower or application of just the general problem of onion skinning. I want to be able to do things that are air gapped, and then I want to private things that are online, things that are hosted, etc.
Yeah, exactly. I think everybody on a certain level wants their healthcare data shared to help power up healthcare to make it better. But most people don't want the fact that they might have had a rash in some place they don't want to talk about exposed to the public. So it's how do you walk that line to where everybody can share in a way that is privacy friendly? All right, next question.
Looks like Josh has some internet problems, and I'm not sure if I think Tim's host now, but yeah, I'll ask my question. The pre-read you shared, that was also very informative, and this is also super dense. But the pre-read was 2013, and I noticed you didn't mention anything about Obamacare and nationalized systems, and I'm assuming they had a big impact on informatics and openness and stuff.
Did.
Can you speak to that? Yeah.
Yeah, oh, it definitely did. So those things helped really drive forward both adoption of healthcare technology, but also moving through transparency of the technology to make it to where you have to move the data. else you'll get zinged for what's called information blocking. But also trying to make it transparent in terms of what things truly cost. Healthcare is built on this weird three-legged table where you've got the patient, the provider, and the payer, be it private, government, whatever. And all three of them, unless the data is connected, don't have the full picture of what's going on. And so all those efforts were extremely meaningful for healthcare to make it more stable, more scalable, but it's also brought in some extra, it's also highlighted some current problems about moving the data around and truly tried to put the patient back in the middle of it all.
So I think my follow-up or second question is kind of related to that. So in recent times, I've seen a lot of interest in both like high-end concierge medicine, as well as like relatively middle class and even poor people just going to, I guess they're called gray clinics or something, not exactly illegal, just cutting out the whole insurance infrastructure. So I guess my question is, to what extent is this complexity driven by the need to deliver better healthcare, like, statistically better risk management and stuff? And to what extent is it an artifact of just administration and insurance needs? And is that the reason the gray market is emerging?
It is due to both. It's both due to a drive for quality, but also a drive of just the overall complexity of rendering the work due to the complicated nature of a lot of paying structures. And that's why you're starting to see some of that gray market appear. We've had a long-standing gray market in the United States around things like plastic surgery, which typically aren't covered by insurance, and it's a straight up cash model. And so you're starting to see that now, not just that concierge level of those who can afford this price could do this kind of work, to where it's truly coming down scale to say, yeah, it is simpler. Some physicians do opt just to go straight up cash because they don't have to deal with the complexities of interacting with the payer system. It's truly, yes, I did the work, here's $5, et cetera. I mean, it's really no different than that country doctor in that Morocco painting who's probably paid with some eggs for taking care of that child and giving her vaccination kind of thing. And the fun thing is, even if we get rid of the complexities of the payer system, we still got to make the data move around. And so we still have the complexities of capturing the work and transmitting the work. So it simplifies it to some extent, but some of the other challenges are still there.
I do have more questions, but anybody else have other questions they want to ask first? I'm looking for the raised hands.
Wait, I've got one.
Oh, yeah, speak up if you have a question. Go ahead.
I should have raised my hand in Zoom, but I guess my question is, how does, this might be a two-part question. How does the conversation around protocols in healthcare like relate to conversation about open source in healthcare?
I think they're one and the same. And that's another reason why the genomic space is a great place to start with this, because they're used to swimming in open source technology, because that's always where you start. Having worked for a commercial healthcare IT company, Cerner, before it got bought by Oracle, I've lived both sides of the street to where here's the private, closed box solution you get, or here's the open source tooling, and do you want to go build your own kind of thing? And so the advantage of looking at protocols in the genomic space is that world is already used to using open source technology. And the fact that there isn't a fully baked business model around that space is very attractive for protocol.
Cool, thanks.
Great. Sounds like, sorry about my internet issues there. David, you have a question?
Yeah, I'm interested how you came to develop that strategy around genomics. Like you had a slide there where you said it has to be homebrew. It's kind of outside of
better to make it go.
Yeah. So it's how did you kind of hit upon that strategy as a route or a plan?
Are you talking about which strategy? You're talking about the one I just mentioned?
You had a slide that you said, okay, we're looking for like this relatively flat area, and there's an opportunity for homebrew creations. Yeah. And then you said genomics. How did you first come up with that recipe of what to look for, or did you see genomics and then back out those attributes?
I've been working in this space for years from the information technology side of things, and it has always been the most complex and frustratingly complex place because there's all this stuff that has to happen to make what you see on the screen, all this genomic data flow that we're building right now. But the conventional business models that we get paid for, like I did work X, I get this, just don't seem to translate because things are scaling so fast and the landscape is so different that it keeps breaking the business models. Things don't work. The payers are so far behind trying to compensate for this work, and the work keeps changing. So you can kind of you can appreciate the situation that a payer's in, like, what? You wanted me to prove this and now it's this week? I don't understand this. And so looking at that space and knowing the typical actors that work in that space, it's perfect for it because they've already got the right mindset. They all want to work together. You don't have this large incumbent thing that's sitting in the middle that you've got to interact with. You've got some legacy stacks you have to deal with, and there's regulatory and stuff, but there's enough of a green space where you can truly get in and say, okay, how can we really elevate this dialogue and put it into more of a protocol layer and orchestrate things? I truly think this is the best place to start in healthcare, that while it's slightly disruptive, it's not disruptive to where you're truly driving, head first into some type of incumbent mindset, architecture, whatever that's in your path. This, I think we can truly bring up alongside the conventional version of what we're thinking about doing with GenomeX and get it to go and be able to be a good proof point. And then if you can do it in genomics, you can take one step over, you can do it in the lab space. And once you get the lab space figured out, then it's not that hard to move into the rest of the world of diagnostics and then the rest of healthcare because you've proven it. Because you're going to have to tackle the things that Dorian started with, like security, privacy, making sure my data is not leaking out anywhere. You'll have to figure those things out first to begin with.
Awesome. Thank you.
Sure.
Dorian, you have another question?
Yeah, I just wanted to quickly plug the capability-based access control. I don't know if you've been messing with that at all.
Not yet.
But that looks kind of like a thing that really could show some promise, especially when you're dealing with a completely decentralized system where the data could be anywhere and you just want to click off a piece of it. That's all. Thanks.
Absolutely.
Any other questions? Go ahead and speak up or raise your hand.
I had a quick question. Can you speak a little bit more to like differences internationally? Like at some point you mentioned that this FHIR is like most of the global infrastructure. So I assume that's by way of export of like software systems made in the West, even including in the developing world and Asia and places like that. So yeah, can you talk a little bit about the variety in international?
Sure. Absolutely. So the FHIR specification is built global with a mind for global first. And so we have a variety of EHR providers around the world that have implemented the FHIR specification. And so you can find those lists on the FHIR.org part of the HL7 website. What we do is we meet as a group, depending on what part of HL7, on a weekly basis, but every 3 or 4 months we get together and we do a thing called the Connectathon. And that is where we have implementers. So be it an EHR provider or some other type of technology provider, they will come and connect with a test system and run a proof of, you can almost call it like a proof of work script, to where they say, okay, yes, I can meet this specification and move this data. IHE has a similar thing with their profiles. And so we use that, we drive all the work to that level of, yes, you went to the Connectathon, because what we want, putting my standards hat on, is we want a standard that is not just built, but it's actually in use. And so we have various maturity levels for all the resources in FHIR. And we want to push everything to where it is truly in use, in production, in a clinical world out there. So you can imagine if we went the route of building up a protocol layer, we would keep taking that protocol layer to an HL7 Connectathon and running scripts, patterns, et cetera, through it and showing this is where we are, this is what we can do, ultimately to where we would get something that would be, quote, certified at a certain layer call it normative, that could be deployed by anybody around, or at least in this case, interacted by anybody. You want to put some sort of, DAO type organization governance on top of it to say, okay, these are the protocols, et cetera, and make that truly a global thing that people say, yes, I agree to this and that. I can plug into it and I can move my data around. But it's backed by not just the vetting of the protocols, but also does it connect and does it truly do what it says it does?
So related follow-up, I think one of the things that international health data sort of already has like an interesting, I don't know, long-term example is vaccination records. So when I moved from India to the US, at some point I was asked about vaccinations. I didn't have them from India. If I had, I wouldn't know how to get them in. And there was, vaccinations play out over like decades. I had actually forgotten what the exact name of the vaccine was. So it seems like relying on institutions to be stewards of this data on a global scale is basically impossible. And the only way out is to have the humans and take charge of their own personal health data and maybe even put it on the blockchain. And it's like, I give people permission to look at my vaccination record across continents. Is that like utopian, or do you think that might eventually be possible?
I think it'll be possible. Personal health records started a couple of, remember when I was at Cerner, we had one, tried to sell one. It was a PHR, you could buy it, institution could buy it. But the reason why institutions didn't want to buy it by and large is because it reduced the stickiness factor. They were worried about the patient leaving that healthcare record and taking it someplace else. But Venkat, you're right in the fact that we should not be relying upon some other institution keeping track of our healthcare record long term. They can go out of business. And you're like, oh, great, I need my vaccine records. So yeah, we have to have a spot to put this stuff into the chain, whatever chain, that is truly permanent, that you control the access to, for sure, but something that can ride above any type of institution, any type of global thing. On the vaccine thing, WHO, I think they've still got a project going on around vaccine passports, to where they were trying to make it to where you could feed in a person's vaccination record into a central type that the patient could have access to and control. So moves are afoot for that, though. It is not currently up and running, though.
So on that, I remember last year I went to Singapore, and for using my COVID vaccination card, there was an option, I think, of like either directly connecting my California digital vaccination record to the Singapore system via the app. But the alternative was to actually, I think, take a photograph of my paper vaccine card, submit it to some process that would get it approved, something like that.
Right.
So I think that's like, we've all learned interesting data point on that front. Yeah,
and the other fun part is, aside from this GenomeX project, if you started at the protocol layer and focused it just on patients and said, okay, what would it take to get your stuff up in there, where you worked with patients directly and said, okay, and you convince people. I mean, think about the leap of faith everyone had the first time they took an Uber. Okay, I'm gonna get into a car that a stranger has that pulled up. I pressed a button on an app and it showed up. If we can overcome that hurdle and say, okay, here's a safe place to just put, let's say, your vaccine records. And we keep growing that movement slowly. You could end up building a PHR on time. You'd obviously have to work with all the in-country regulators, et cetera, to make sure it fit with all the regulations, but that's also a good place to start.
I think we have time for maybe one more question. If anyone's got a final thought or inquiry.
Yeah, I had a question. Could you talk a little bit about the tension in terms of maybe the standards and the data structure? Because it feels like every institution participating in this, like whether they're a physician, they're an insurance or a pharmacy, are each kind of like lobbying for their own. And we're as a system, we're getting the short end of the deal, which is no one is happy and the standard sucks.
Exactly. Yeah. That standard, the code side of the standard system has become a little bit of a battlefield, but what we try to do is to harmonize code sets where we can, to truly make it to where, if there is a code set that you need, so let's take, for example, I'll use the lab space. So there's a code set called LOINC that describes how you did the test. Then you've got code sets that show you, like Snowman, of what did you find when you did the test, things like that. And so we try to harmonize those code sets. That way it's just not death by up-down conversions going between this format to this format. Yes, they're all standards, but why can't we have just one? So we at the standards level work really hard to make sure our stuff moves in concert with things, to try to minimize any kind of weird redundancies. we're always going to run into things to where, based on this region or this industry, they want their own type of code set. But we'll work to make sure those things get translated back and forth. Does that make sense?
Yeah, that makes sense. But it also makes me think about the challenge between like international, like healthcare sharing, because even the coding for medical conditions varies. And so you know, something that's coded here is coded differently there, and across insurance, like stuff is coded differently too.
Exactly. And that is actually one of the bigger challenges with, let me go back real quick. I know we're at time. This on-ramp to get the data up, there's a big data normalization step that has to happen. And that's where a lot of our initial work is going to be, to make sure the code sets match up so you truly know, what is this thing that you put into the repository? Do I understand this code?
Yeah. Yeah. It would be really interesting to try to develop a, like you mentioned, like an open source protocol that actually provided the right level of flexibility. Really interesting.
Yeah, exactly. That's what we're hoping to do with this other type route. So initial network for me though is to kind of look at how to connect on the fire side up to, say, a Chainlink API, something like that, to start to put some basic framework around what would a layer 2 kind of look like. And then sort of see, all right, can we, you know, it's possible to look at this from a public funding option, like, go after a Gitcoin grant, that kind of stuff, if I can get enough developer interest in it. So, and kind of let that ride along in concert with the traditional route we'll also be taking to build the storage appliance.
Amazing. Thank you so much, JD, for your time and for engaging with us today.
Absolutely.
There, I'm sure, will be further conversation in the Discord thread if you guys would like to join in there. Otherwise, we will see you on Friday at 11 a.m. Eastern Standard Time for another guest talk in the series. So once again, thank you, JD.
Cool. Thanks, folks. Talk to you guys soon.